Welcome to the recorded version of the Grantmakers and Aging web seminar, Advanced Planning for Regular People and Physician Orders for Life-Sustaining Treatment, featuring Charlie Sabatino, Director of the ABA Commission on Law and Aging, Nancy Zweibel, Senior Program Officer at the Retirement Research Foundation, and John Feather, CEO of Grantmakers and Aging. From April 5th, 2012. This event was made possible by a partnership between Grantmakers and Aging, the John A. Hartford Foundation, and the Retirement Research Foundation. Technical and production support is provided by the American Society on Aging.
Welcome to Conversations with GIA. This is the third in our continuing series of monthly webinars on critical topics of interest to funders in aging. Today's session is entitled Advanced Planning for Regular People and Physician Orders for Life-Sustaining Treatment. My name is John Feather, the CEO of Grantmakers and Aging, and I am delighted that so many of you have joined us today. Before we begin, I want to thank two of our members for their support in making today's webinar available free of charge to funders in aging. The John A. Hartford Foundation of New York is providing continuing support for this series, and the Retirement Research Foundation of Chicago is co-sponsoring this month's webinar. I also want to thank the expert team at the American Society for Aging for their providing technical support and production support for the series. Today's conversation with GIA turns from the national and state aging policy to ways in which philanthropy can work with local and state coalitions around the traditionally complex issue of advanced care planning. As funders in aging, GIA members are concerned with assuring that health care for persons with advanced illness reflects what the patients want as their illness progresses. The legal and practical paradigm for advanced care planning and decision-making near the end of life has evolved dramatically over the last few years. This program describes a growing movement involving local, regional, and state coalitions working to engage and enable health providers from long-term care, hospitals, home care, and emergency response in learning and honoring patient wishes. Joining us today as our expert panel are Charles P. Sabatino, Director of the American Bar Association Commission on Law and Aging in Washington, D.C. Since 1984, he has been responsible for the ABA's commission's research, project development, consultation, and education in the areas of guardianship, health law, long-term care, capacity issues, surrogate decision-making, legal services delivery for the elderly, and professional ethics. Mr. Sabatino is also a part-time adjunct professor at Georgetown University Law Center, where he has taught law and aging since 1987. He received his AB from Cornell University and his JD degree from the Georgetown University Law Center, and he is a member of the Virginia and District of Columbia bars. Dr. Nancy Zweibel is Senior Program Officer with the Retirement Research Foundation, the country's oldest private independent foundation devoted exclusively to making grants to improve the quality of life for older persons. She has been with the Retirement Research Foundation since 1999, overseeing program evaluation and managing a portfolio of research, training, advocacy, and direct service grants. Her doctorate is from the University of Chicago School of Social Service Administration. Nancy, let's start with you. This slide says that the end of life is changing. Obviously, the final outcome of the end of life has not changed. So what do you mean by this statement?
Well, I think it's important to have a context. This information really isn't news to many of the people on the line, but it is important for us to keep in our head as we have this conversation how death has changed over the last several decades. Most importantly, obviously, life expectancy has risen dramatically. And what that means is that of the nearly 2.5 million deaths in the United States every year, almost half are among persons who are ages 85 years of age or older. The second thing I guess it's important to point out is that death has become a more drawn-out experience. Before medicine got good at extending life expectancy, in persons with chronic life-limiting conditions like congestive heart failure, kidney disease, dementia, and cancer, death was more frequently either a sudden event or it occurred after relatively brief periods. I mean, relative to what we're experiencing today. But today, death is increasingly a slow process of decline with a lot of uncertainty about patient prognosis, substantial burdens to patient quality of life and families' quality of life and mental health, and a lot tougher set of decisions facing medical providers. And so I think patients are increasingly forced to consider the balance between length of life and quality of life. And in fact, we see that in the survey data shown at the bottom of the slide, which was a survey done by the National Journal and the Regents Foundation. And in February of 2010, the data was collected on 1,000 adults in the United States. And you see that nearly 3/4 of them recognize that there may come a time in their lives or in people's lives when quality of life is more important than length of life. So that's what I mean when I say that death is changing.
Philanthropy has been involved in promoting advanced care planning for a long time. What has been the role of foundations and other grant makers?
Well, I think the biggest role has been in improving access to hospice and palliative care. Foundation investments have been huge and dating back to primarily the early 1980s. RWJF recently did a retrospective on their grant making in this arena, and they've really played the lead role. And just to give you a sense of where things were when they started, they point out that patients in those days were seen as failures of the medical system who either received excessive life-extending technology because there was no available cure, or the reverse. All care was withdrawn and there was no attention to the issue of suffering. But since then, RWJF has invested over $170 million, and Soros, I don't know exactly how much relative to the RWJF investment, but also an extremely large set of grants. And as a result, we now have advances in a variety of areas. We have more professionals trained to deliver hospice and palliative care. We have broad expansion and access to hospice and palliative care. There's been extensive public education about advanced directives and advanced care planning, although we'll talk soon about what the limits of that have been. And we've also seen improved clinical approaches to controlling pain and other symptoms in persons who are dying.
Charlie, let's turn to you. Advanced care planning has been around for a long time. Could you walk us through some of those efforts and the problems that have been encountered in implementing them?
Sure. This really goes back more than 35 years to the mid-1970s when this came to the fore in the policy world. And the response was to create some new legal tools. Originally, the document, medical directive, more commonly called the living will, which was simply a document that enabled you to spell out your instructions at end of life of what you wanted or didn't want. And about a decade after the living will, the healthcare power of attorney document came into the forefront. And these are recognized in every state now. The healthcare power being the document that enables you to legally authorize somebody else to speak for you when you can't with respect to medical decisions. And the problem is that both of these documents were a bit oversold in what we could expect from them because over the decades we have learned that individuals are still generally reluctant to use them. When they use particularly the instructional kind of documents, the document often doesn't provide useful guidance, and people's preferences change as their condition changes. Very often doctors aren't aware, even if there is an advanced directive, as these are more generically referred to as advanced directives. Even with having to check a box whether a person has one when they enter the hospital, They often don't get in the record, or they're hard to find in the record. They don't follow the patient across care settings. They don't get updated easily as circumstances change. So large barriers in the original model of advanced care planning that we created.
Obviously, this is always a difficult issue for patients and families, as well as caregivers in the both professional and informal sense. But new approaches are emerging. Charlie, could you describe the new way of looking at this issue?
Yeah, and this is really a response to the barriers I just described. One way of looking at the original model is as a legal transactional model. You know, the living will was modeled upon a will or a trust document, and it kind of conceived a one-time event. It used forms that were legal forms, largely written in statutes. Often they had formalities such as required witnesses. Sometimes they required certain language or notices. So it was very much a legalized model. And it has, because of what we have learned, moved much more towards a more flexible, what you might think of as a conversational model that is less focused on formal instructional documents, more focused on a guided discussion between the individual, their healthcare providers, their proxy family members, and it's more broadly focused on one's life priorities and goals of care, rather than trying to be specific about particular medical interventions, which most of us really don't have the training to know much about the particular medical interventions. And also, there's a conversation that has to keep going. It is not a one-time event. It's developmental in nature. An 18-year-old who is doing their advanced planning is not going to be approaching the subject in the same way as the 85-year-old who has multiple chronic conditions and who has experienced deaths in his or her lifetime.
Charlie, once again, what tools and resources are available?
Well, this really are examples of how this movement towards a conversational approach has been facilitated. There have been a significant rise in very practical tools to help people have the structured conversations that they need. I include a couple here that are free. They're on my program's website, and they were created as a result of grants from philanthropy. One is called the Consumer's Toolkit for Healthcare Advanced Planning, which guides people through a number of provocative questions about what their priorities and values are with respect to healthcare, provides some informational material. The other one, Making Medical Decisions for Someone Else, the how-to guide, is specifically for educating one's proxy or healthcare agent, because that is a role that most people have no idea what the responsibilities are. There's no standard job description out there when somebody asks you to be their healthcare proxy. This movement towards the conversational approach has also been helped by much better training of providers. Now, there's a long, long way to go in that, but there are some really good models out there. And from a kind of a social change perspective, we keep looking for ways to build in more prompts into both the healthcare system and society in general for people thinking about this. You'll recall with the healthcare reform bill, one of the things that had come up in the when it created an annual wellness visit for Medicare beneficiaries is what would be included in that wellness visit. And the Department of Health and Human Services originally in their final rule included an annual opportunity to have a advanced care planning conversation. And that got pulled very quickly by the administration because frankly, because they were fearful that it might raise the death panel concerns again. But, there are other opportunities that others have promoted, such as when you obtain or renew your driver's license. Maybe that's a good time to give people information about advanced care planning, because auto accidents are one of the biggest causes of people being impaired for a lifetime. So these are all items that have helped move the field in the right direction, I think.
This really gets us to the heart of the matter. But even with meaningful reflection and deliberation, how does that get translated into a real plan of care for people with advanced illness? And with the next slide, Charlie, now that we're here to the real core of what we're talking about today, could you describe a new paradigm that is emerging to better link patient goals with an actual plan of care?
Yeah, POLST stands for Physicians' Orders for Life-Sustaining Treatment. Now, it's called by different names in different states, but it is a paradigm that was created by asking this question. What really drives what happens to you in the healthcare system when you are ill and you can't speak very well for yourself? Well, what happens in the clinical settings is either happens because a doctor has ordered it, it's on the order list, or it's a standard medical protocol that everybody's been trained in and they have to follow. One's wishes about their goals of care, et cetera, are sometimes hard to break into that process unless you're very strong-headed, or unless unless somebody could come up with a protocol that makes sure that it gets factored in for patients who have advanced illness for whom it is most important. And that's what POLST does. It bridges this gap between your goals and preferences and actually implementing it in a plan of care with teeth. And when I say with teeth, I mean it's a medical order. So POLST involves 4 steps. First, a structured discussion with the patient or their proxy about their goals of care when they are in an advanced state of illness. So this isn't for the healthy 18-year-old. This is really for somebody who's dealing with serious progressive chronic conditions. And their goals and their wishes are then translated into a set of medical orders that address high probability emergencies. What if your heart stops, your breathing stops? That's CPR. What are your overall goals of care in terms of either aggressive treatment on the one hand or purely comfort care on the other, or something in the middle? What about nutrition and hydration artificially supplied? Should that be provided? And some states actually also address antibiotics. There's no absolute list of what you can address, but these are the most high priority questions that come up in the face of crisis. And so these are translated into a visually distinct set of medical orders that becomes a cover sheet to the file. If you have paper files, if you have electronic files, it becomes a visible tab that should be on the very first page of the electronic medical file. The other 2 steps are that the provider's obligation is to ensure that these orders are transported across care settings. And lastly, they must be reviewed whenever the person's health status changes or their venue of care changes. So these are obligations put on the system, on the providers across systems, rather than relying on the individual to try to truck around their advanced directive and make sure you follow their wishes. Now, these don't take the place of advanced directives. It is a process that builds upon one's advanced directive, but it focuses on the last stage, the end stage of one's condition, where making sure your wishes are translated into medical orders is more important than at any other time of your life. And finally, if you haven't gotten the point already, POLST is a process. It's not a form, but very often when it's talked about and people look at a brightly colored pink form, they think, well, POLST is just a form. That is only a part of a much more robust process of determining a patient's wishes and creating a plan to follow them.
Nancy, do you have anything to add about the POLST process before we move on?
Yeah, I wanted to point out, and as Charlie used the word, it's a process with teeth, and referenced the fact that it's a signed medical order, and I think it's important to underscore that because the literature makes it very clear that doctors in the emergency setting and in ICUs often report feeling that they have no choice but to impose life-extending care on folks who might not want it because, they don't have any direction to the contrary, and they're far more likely to listen to one another than they are to listen to even family members, because they know that often family members have had disagreements with one another and maybe aren't the best road to follow. So I think having that that medical order is a vital part of it. And the other part of it that adds teeth is that in most states already that have POLST programs, we're going to talk about that in a minute, one of the first steps that gets taken is that the state statutes with respect to advanced care planning are often revised, either the statutes or the regulations around these issues are revised to explicitly accept POLST as a part of the advanced care planning spectrum. And that lets the EMS folks in the field who may be responding in ambulances to people's homes have a protocol that they can plug in and respond to someone who may be imminently dying without fear of liability, and feedback from those communities in the states where this has taken place has been uniformly one of relief and acceptance, because they rarely like having to impose ventilators and the like on people in the absence of any guidance.
Charlie, how widespread is this program?
Well, I'm going to answer that on the next slide. On this slide, I'm going to point out one of the biggest problems when POLST is introduced is the confusion between POLST and an advanced directive. So I wanted to spend another minute on explaining those differences so that people are clear about them. And this slide does a really good job of comparing them side by side. First, the population. All adults should be doing advanced care planning. Get your 20-somethings to make sure to sign their health care power of attorney, so they at least have named somebody who can speak for them. But for people with advanced progressive illness, POLST goes several steps further, which is the time you need to do that. And so the time frame for POLST is also your current condition. You're not talking about some future hypothetical situation as you are when you're doing your advanced directive. You're talking about what are we going to do if this happens to you in the next hour, because that is the time frame for POLST. POLST is completed in a medical setting. Advanced directives people do in their home or sometimes in their lawyer's office or anywhere. And the resulting product for POLST, as I have already said, is a medical order. For an advanced directive, it is an advanced directive, which is really an advisory document. It is not automatically self-enforcing in any way. Surrogates cannot sign an advanced directive, even close family members, but depending upon state law, a surrogate can sign a POLST form. And most states do have a process for a default surrogate, as well as your healthcare proxy, the one whom you have named, can sign it. Portability for POLST is the provider's responsibility, as well as periodic review, and that's different from an advanced directive. So those are key differences between the two that to keep in mind.
Thank you. As we move to the next slide, and before I ask Nancy to describe this, I do want to remind our audience that we are open for questions. There is a box on your screen that allows you to type in questions that we will then read to our panelists and ask them to respond to. So Nancy, would you like to talk a little bit about how widespread the program is and how it's moving forward?
Yeah, and it's interesting because this slide shows a date of February 2012, but just yesterday I received an email from the National POLST office, which is at Oregon Health Sciences University, and it's now out of date. So what Susan Toll, who directs the program nationally, sent me yesterday was that there are now 14 states that have POLST programs that are officially endorsed by the national office. You don't have to have the national office's endorsement, but they set a very high bar for giving their imprimatur to your program, and the imprimatur is really just designed as a way of saying that we've made strong suggestions on a variety of parameters of POLST that we see as important in our 20 years of experience in doing this, and if you achieve those, then your program is more likely to produce the kind of end-of-life care that people want in the way that they want it. And so you have those are the dark pink states, and there are now, I think if you count the ones that are on the slide, there are 13, but one of those states that's light pink has subsequently flipped to dark pink. I don't know which one that is. There are also 29 states now that are in the light pink category, many more than you see here, that have what they call developing programs, and those are states where there is an identified contact and usually a coalition that has already been formed that incorporates the broad spectrum of the various stakeholders that have to be at the table and buying into this, because not only is this a process for individuals and their providers, it's a process as states develop their coalitions, and it requires input and agreement and cooperation among hospitals and EMS systems and home health agencies, among nursing home providers and hospice and palliative care providers, internists in the community and the like. And so those light pink states are working to develop coalitions. There are only 7 states now in the country that have no POLST contact or coalition. So we really are moving quite quickly. I won't say that RRF is the reason things are changing so quickly necessarily. There was big momentum behind POLST before we joined the bandwagon, but we did recently make a, for us, quite large 3-year investment in helping to allow the national office to respond to that increasing demand for their technical assistance, and also to seed some of the states that had the greatest potential. And I want to also use this slide to go back and say something that I neglected to say earlier on the role of philanthropy, and that is that there have been several place-based state and health conversion foundations that have played substantial roles in the development of the hospice and palliative care and end-of-life planning field and policy, including investors. The California Healthcare Foundation, for example, is pretty much single-handedly responsible for the work that is spreading POLST in California, and several other funders as well.
Charlie, on the next slide, let's return to you. How well does this process work?
Well, that was actually a question that we had a couple of years ago when we wanted to find out what enabled the process to move forward in states, what barriers they faced, and how they overcame them if they did. And we teamed up with the AARP Public Policy Institute in 2010 to do a survey of the 12 states who had POLST authorized statewide at that time. They didn't necessarily have it implemented fully statewide, but they had it authorized statewide. And in those states, we did several things, but the key thing here was interviewing extensive interviews of 53 key informants across those 12 states to quiz them on what facilitated the process to move forward and what got in the way. And the second bullet here highlights the top facilitators of the process across these states. A core group of physician champions, as people tended to refer to them, was really essential. Physicians are I think at the center of all the target groups because you need their leadership. They're the ones who've got to sign these orders. So having at least the core group that can help spread the word was important. Devising an incremental strategy was something that almost every group realized. At the beginning, it looks like, okay, we've got this authorized, let's just do it. And it doesn't just happen. It really is a multi-year strategy to make this penetrate practice in all kinds of settings statewide. A third element was the existence of a statewide coalition and local coalition that worked well together, that was highly diverse. The more diverse, the better. If you just had a group of physicians doing it, for example, even though I said they are essential, it wouldn't work. They really have to go beyond one discipline and one setting. And finally, the availability of financial support for coalitions, either in cash or in kind. This is kind of the real world aspect of this. It really didn't take off unless there were the resources to make it happen, because there are so many things that you have to do to get this going at the state level. The last item, Nancy, you might want to respond more to. You already mentioned the Retirement Research Foundation initiative, which the last bullet refers to.
Yeah, just to say that, to build off what you just said, the reason we felt comfortable making this investment was the fact that Charlie and AARP had done this survey, and so we felt as a foundation that first of all, there's an evidence base. The National Post Office did a randomized controlled trial, I believe it was, in which they did document that where Post was used, people's deaths occurred in the way that they wanted them to. I think it's important to point out here that we're not just talking about people who want care limited. We're also talking about people who want all possible care provided, a concern particularly of certain ethnic groups and the disability population, where the fear is that their lives will somehow be seen as less meaningful and therefore prematurely allowed to come to an end when that wouldn't be what they would want. So anyway, we felt like there was data, and we felt like there were good guides for how this worked well, and the national office really understood how to provide the technical assistance and advocacy. And so that's what our money is buying, in addition to a set of pass-through grants that the national office is offering to five states for their coalitions, and then to another set of I believe it's 9 to 10 states for smaller grants to help them with their local coalition and state coalition efforts.
Charlie, if the process works so well, what's keeping us from using it?
Well, this slide summarizes the other side of the study we're just talking about. What were the barriers and salient issues that groups ran into at the state level? And clearly the top item, the top challenge, was training on how to have the conversations that lead to the POLST set of orders that then follow the patient. Training is a multi-level task. It's ongoing. It requires system support once the skills are learned. If you train people, for example, in a nursing home, which is a very perfect place for this for POLST forms to be done and updated. If you train them, but they don't have the time to do it with patients, then they don't have the system support they need. So training is a huge issue. Other issues that people ran into probably won't be a surprise to you if you think about it. One, what is the nature of consent that you have to get from the individual for the POLST form? Should it require a signature? It certainly needs their informed consent, but how do you confirm that consent? What should be the content of the form? That always takes up a lot of energy of the groups that develop POLST to make it objective. And as Nancy said, the form is not all about stopping treatment. It gives you options from totally aggressive treatment to total comfort care and everything in between. Confusion between advanced directives and POLST, we've already talked about that. Looking forward, states who have POLST are struggling with how to integrate it into electronic health records. Who can be a surrogate to sign POLST is typically an issue that comes up in states. Changing institutional protocols and policies and procedures is an institution-by-institution challenge. And then there are perceptual barriers. One of the most common was that among healthcare providers is that POLST would be too time-consuming and cumbersome. But once it gets going, people realize that this is really not only a time saver, but a real boost to patient-centered care. And finally, cross-cultural issues, how to make the process amenable to very different cultural norms is a task we have really across the health system, not just with POLST.
Let's go to the next and last slide. And Nancy, we'll return to you. You've talked some already about how funders and philanthropy can be involved in this process. How do you see them involved more aggressively as this process moves forward?
Well, I think the thing to keep in mind is that I like to think about it in terms of different types of funders, because for the funders on the phone, I'm sure you'd shake your head yes when I say that if you know one funder, you know one funder, and everybody has their own mission and program guidelines and so forth. But there really is a lot of room to play here. So I think about it in terms of family foundations, conversion foundations, and community foundations. And there are several ways that their money can come into play. For those that will fund training, as Charlie said, there's an enormous need for support of coalitions so that they can create a cadre of trainers that are available and have the resources to go out to various regions to, at two levels, train providers, both at the general level about what POLST is and how it works, but also at the more intensive level about how to implement POLST, how to have good conversations, and so forth. I think the second area where funding is greatly needed, as we pointed out, is that coalitions need that backbone support. In several states, POLST programs are housed in university settings where they have bioethics centers already, and so promoting POLST is an appropriate way for the staff who are funded in those centers to devote their time. But that's not the case everywhere, and the coalitions, although they don't need a lot of money on an annual basis, having at least enough money to support a full-time or substantial part-time coordinator who can organize all the coordination, who can develop and oversee quality assurance methods, who can be the media contact and essentially the center of all operations, working to support a statewide or regional task force, and then the various work groups that organize underneath them to make this happen. And finally, I think in particular community foundations have a role to play on public outreach. It's important that the healthcare agents and proxies know about this, that older adults or other people with life-limiting illness learn about it, because the more they can go to their doctor and say, I want to talk about this, you haven't asked me about this, the POLST form provides a structure for those conversations. And if you look at the literature, it's very clear that patients will often say that they want to talk about this, but their doctor never brings it up. So I think those are several of the most important ways foundations can play. And I guess the last one would be the funders that are in the disease-oriented category that maybe work to address issues of patients with cancer or Alzheimer's. These funders, maybe focus primarily on causes and cures for their diseases, but they also need to pay attention to the current struggles of patients, and POLST is a great opportunity for them to help those folks that they aren't going to be able to cure find the best way of managing the end of their lives.
Well, great. I want to thank both of you for this presentation, and I now want to move on to the questions that our audience has provided. Just a reminder to our audience, you can submit questions on the box that you see for the questions. And I'll start with our first one. And I'll ask both of you to respond, but we'll start with you, Charlie, because you've raised this issue a little bit in our presentation. But the last time the government proposed promoting advanced care planning through Medicare reimbursement or counseling requirements, there was an enormous commotion over death panels. Won't philanthropic groups face the same flack and difficulty if they promote this?
Well, the key thing that you said there is the last time the government proposed this. That's where the problem comes in. Many surveys have shown that Americans want to discuss end-of-life issues, and even the 2011 survey that was mentioned earlier found that nearly 80% of adults answered yes to the question, do you believe that there should be more of an open debate about public policies regarding these health and life issues, end-of-life issues? The public doesn't have a problem talking about this. And it doesn't matter in the survey whether you were Democrat or Republican. People felt the same way. There's great similarity in views. The problem is when the government pushes it, the topic gets bogged down in the whole other set of issues about the government's role and big government and all that. So the private sector is really where it's at, and Nancy, you may want to address that.
Well, I just want to say that the real pushback that philanthropists, and it's not, it's an accurate thing to say, and that is that POLST is not about limiting care. I said it before. It's about giving people the right to make the confidence that the preferences that they state, whether they are for limited care or for all possible aggressive efforts to maintain their lives, are honored. So this isn't a death panel. This is a decisions about death issue. And so, if philanthropists get that, that's the view that we took here at RF at any rate.
Charlie, you mentioned earlier that the POLST model helps ensure that medical orders are transported with the patient across different care settings. How does this actually happen in terms of does the patient carry them out of one facility to another? How does this work?
Well, it's a changing picture because we're moving towards electronic records, of course. But in the paper world, where this is all developed in the last 10 to 20 years, it is primarily a provider responsibility. Often these POLST is initiated at a hospital, a point of hospital care, because that's when it becomes clear that a person has entered that stage where curative treatment is not necessarily having the effect it has, and the person is being rehospitalized a lot. So when the patient leaves the hospital, if they're going to a nursing home, the states have all done this a little bit differently, but they generally have a process for notifying the nursing home ahead of time that there is a POLST form, faxing it to them. Copies of these forms are fine, and when the person gets to the nursing home, they're supposed to review it anyway and update it, and so a new one would be done. But it's in the transport that you want to make sure that everybody is aware. If they're going home, a common practice is for that form to be put in on the refrigerator. The EMS personnel are trained to ask about it and to look for it. If they are going to transport a patient, they would take the form with them back to the hospital. Likewise, if a person is going from a nursing home to the hospital, they've got an obligation either to include it, either the original or a copy of it with the patient, or to notify the hospital if that's possible. The feedback I hear from our colleagues in Oregon is that they have gotten so well established that if a patient shows up from a nursing home without a POLST form, the ER doctors there are a bit angry and consider that a medical error by not providing that information. And that's really kind of the culture we want to see happen. Electronically, the great thing is Oregon is another state that has always been in the lead in this. They have created an electronic registry of these forms, which is mandatory. Every time a POLST form is done, it has to be submitted to the registry unless the patient himself or herself declines. And in their first year of doing it, they had 25,000 plus POLST forms in the registry. And the EMS personnel can, by phone, find out if there's a POLST form while they're on their way on a call, and find out what the content of that form is, or have it actually faxed to them en route, or transmitted to them en route, so they can actually read it. And that is the direction I think we're all going.
Well, let's follow up on that. Obviously, this can be a complex process because our healthcare system is enormously complex and very fragmented in many cases. Isn't there a danger that support of an initiative like this could backfire if POLST is done poorly? You emphasize that it is a process and not just a form, but can't the form potentially be misused in the wrong hands to create orders that patients or their surrogates don't really understand?
Although that is a danger. I mean, all advanced care planning can be done well or very poorly, depending upon the knowledge, skill, and good faith of those involved. But this is exactly where groups, philanthropic groups and other groups can have a potentially huge impact by supporting efforts that raise the standard of practice and knowledge to the highest level. You can't legislate optimum practice. You really have to change the system, change the culture, and provide the support to do that.
And I can just add, John, that the states that have been at this the longest have realized the need for and have implemented a process where every year or two they audit the records of the nursing homes, of the home health agencies, and the hospitals, and they look for indicators of appropriateness or inappropriateness. And when they find a pattern, they work to correct it. So I would recommend that for any funders that may want to get involved in this arena, that they make sure that any efforts that they support have that built-in quality assurance.
Your point also highlights the fact that while a diverse interdisciplinary group is important to get POLST going in a state, it's important that that group continue on, because this process really requires input through all levels of the health system in order to review what's going on and how it needs to be improved. The folks in Oregon have been doing this for 20 years, and they say that they make changes in the protocol probably on average every couple of years, because medical care is changing, what they are learning is changing, and that ongoing process of quality improvement is vital to the health of the program.
Let's move to our next question then. Does POLST or advanced care planning in general save money? And if so, does that cast doubt on the motivation of providers or the government or even philanthropic groups that support these kinds of initiatives? Nancy, you want to take a crack at that one?
Well, undoubtedly it does, but that's not why people do it. In fact, there hasn't really been a great deal of emphasis on even studying the cost implications or any savings that come from this. That being said, it's true that if you look at the forms that have been completed in the states where this has been going on for quite a while, they are heavily weighted toward folks who prefer to have limits on the amount of care they get relative to folks who prefer all forms of care or more aggressive care. And so clearly this is an effort that does yield savings. But the motivation here is about making sure there's good person-centered care. It's not about money.
All right.
If I could add to that, a really interesting finding in a study that was done of the Oregon electronic registry outcomes after the first year was that of the people who said they wanted to do not attempt resuscitation order, half of those people still wanted some limited interventions beyond purely comfort care. That there is an assumption with living wills and advanced directives that when somebody says, I don't want, at this point, no more care, the literature has shown that there tends to be an assumption among healthcare providers that means they don't want anything. They don't really go behind the overall message. Whereas with POLST, it's very it shows how nuanced it can be by allowing someone to say, do not attempt resuscitation, but I do want you to do some other things that may make a difference to my my treatment and care on top of purely comfort care.
We have time for one last question before we ask our panelists for their final comments. If the movement towards the POLST paradigm is so strong, won't it happen anyway without major involvement of philanthropic groups? Nancy?
It may, but it will take a lot longer, and it will happen at a much smaller scale. And I would say that with 1.2 million deaths among people who are 85 years of age and older every year, being in this chronic illness with quality of life burden category, we don't. It's an area that we are, at least at RF, feel we have a responsibility to address and speed up. So, and as I said, it doesn't take a lot of money for a given coalition necessarily. Frequently, the coalitions get a lot of in-kind support, a lot of pro bono time gets donated. But the education, as Charlie pointed out, is something that has to get done well to do this right, and it has to be ongoing. New providers come in that haven't been trained. There's turnover in staff at nursing homes and so forth. So a steady stream of moderate amounts of money is really all that's needed to make a difference sooner rather than the slow accumulation of progress we might see without it.
And of the 14 states out there that are now endorsed states, I only know of one that gets a penny of state money to oversee the program. Certainly every state's health department has had to be involved in the planning of the program and approve it, and may even have stuff online about it. But the real oversight of these programs has been done by these state coalition groups or university-based group on the private side. So that process is what needs the support.
And I would say that anybody on the call who wants to explore can go to the POLST.org website, and it's literally POLST.org. And you'll see the names and contact information for folks in every state of the country where there is a contact. And, if you go to the states that are in bright pink, you can talk to people who've been at this for a while and find out what level of resources they have and what they have and haven't been able to accomplish as a result.
Well, Nancy, let's continue with you. Any final thoughts for our grantmaker community today?
Not really. I guess I just would offer myself up as a resource. If anybody has questions, they're more than welcome to call and ask what RF is funding in more detail and what states are being supported and the like. And again, I would just encourage folks to go to the POLST website because in addition to the map and the contacts, there's a long list of research on POLST and other resources for training and coalition development that are available for viewing.
Charlie, your final comments?
Yeah, we've been talking a lot about POLST, which is a particular protocol in and of itself, but it's important to see that in the broader scope of both advanced care planning and palliative care, which are both evolving, in our society as we speak. But POLST is really, to me, one of the wonderful things about it is in order to do it well, you really have to have a multifaceted impact on society to make it work, because it involves empowering consumers, it involves changing the healthcare delivery system, it involves improving public and private policies, it involves enhancing provider capacity, so that there's just so many levels to the effort that not only does it help create this protocol we're calling POLST, it really helps improve end-of-life care, palliative care, and chronic care in the big picture as well.
Well, thank you. I want to thank Charlie Sabatino, the Director of the American Bar Association Commission on Law and Aging, and Nancy Zweibel, the Senior Program Officer with the Retirement Research Foundation, for joining us as our panelists today. Thank you both for everything you do to make life better for America's older adults. I also want to thank the John A. Hartford Foundation and the Retirement Research Foundation for their support of this program, as well as the American Society on Aging for their technical expertise. Remember, we need your suggestions for future topics and speakers for conversations with GIA. Please send us your ideas. And finally, I want to thank all of you for participating in today's webinar. Have a wonderful day.